So now the next session is Master Stock Cataract Session 2. We have, Acha, good. We have Dr. Ramamurthy with us, exactly on time. I would like to welcome him as the chairperson for this session. We have Dr. BNR Subudhi, sir. I'll call him. Dr. Pinky Pal is here. Can you please come forward? Co-convener. Dr. John Sarkar. Okay, good. So do we have Dr. Anaga Harur here? Anaga को phone लगाना. यहाँ पर it's written Anaga Harur. But anyway.
Very good morning, everyone, and I think we have a nice session ahead of us, and without wasting much time, let's get on to the first topic, and that's going to be given by Dr. Chitra on tackling IOL discrepancies in optical biometry readings.
A very good morning to a very good morning to all the moderators and dear audience. My due is to talk to you all about what are the discrepancies which you should look for when you're doing an optical biometer reading and how you circumvent some of those issues. Basically, we know that we have the best of IOL designs, the best of IOL power calculations, the best of formulae which we have, biometry too. So now the success in a surgery is whether you are within plus minus 0.5 diopter of the target emmetropia. And actually, if we realize that if we are not, then if we accept it as a failure, that is when we are going to be geared to give this kind of success to our patients. Biometry is actually just a simple arithmetic with measurements and assumptions. So essentially, when you feed in your post-op target refraction which you want, the issues which are asked for is the axial length, the K and the effective lens position. Now we are at an unsurpassed accuracy as far as our axial length measurement is concerned, but the corneal power continues to be a challenge because especially in those post-refractive surgery or eyes which have been surgically treated and more so, and effective lens position is again a huge challenge which I would be discuss with you all as we move on. So these are the challenges which finally is going to help you come to a IOL power calculation. So we realize that some are accurate, some are some assumptions, which is where the discrepancy comes. You could be lucky to have a post-op refraction of 6.6 both eyes, but you could also have this. So does it mean that a post-op refraction of 6.6 both eyes, is it that one error on the one particular reading cancelled out the other, or is it they were just too perfect a measurement? But there may be a time when you will have a refractive surprise, and that is when it makes you want to go back and understand how to do it better. This what all I told you already was also discussed by Norby et al. In 2008. So then what was further analyzed in this particular graph was that if you use the third generation formula, you may do well in majority of the situations. But in those extremes of axial length and in these post-surgically treated eyes, you need those latest generation formulas to get you that kind of end result which you want. This was another study again where they compared the Hill RBF with the EVO and the Barrett's, and it again reiterated the fact that when you're using these formulas, you're well within 92% of the time you're within plus minus 0.5 diopter. So what do? I'm keep throwing so many options to you. Does it mean you keep typing in multiple formula and then decide which is the most accurate measurement? Or you look at your results and choose which is the best and stick to that for your own by analyzing some 100 eyes. So it is most important that we consider these pearls. We should measure both eyes in all patients. Now this was a patient who had a PSC cataract, and it was done on immersion biometer, and the axial length, that exclamation mark is there. And you also see that the IOL power in the right and the left eye is quite different. So then immediately you should go and repeat your immersion biometry measurements. You remove all those outliers, take those eyes which are going to be average, and then you get your final accurate answer. But incidentally, of course, you need to see whether the spikes are of equal amplitude, the gain is low. You should see that the standard deviation is less than 0.06. You need to be very accurate. And incidentally, we repeated the optical biometer in the next day, and it was 22 in both eyes. But then the immersion also said it was 22, and then you are convinced to go about it. You should always measure, even if the other eye is a pseudophakic eye, you should look at that eye also, because it gives you information about the axial length, the corneal power. So if there is some asymmetry in these situations, you need to repeat your reading and cross-check. You should remember that if there is a difference in the axial length between two eyes of more than 0.3, if the K between the two eyes differs by more than 1 diopter, and if the IOL power between the two eyes differs more than 1 diopter, you need to be repeating your measurements. You need to look at the raw data. On the optical biometer, you should look at those LED points. Does it have a fishtail appearance? Now this was a patient who had a 0.5 diopter in one eye and 2.6 diopters of astigmatism in the other eye. But when we looked at him in the slit lamp, we found there was so much of SPKs and filaments. So after treating the dry eye, when you evaluated him, it was actually 0.2 in both eyes. So if there is dry eye, we need to repeat our measurements. We need to see whether the signal to noise ratio is more than 2. We should see whether the standard deviation in your readings is less than 0.2 or 30 microns, especially in a normal eye. You'll find that if it is in the normal range of axial length and anterior chamber depth, you would find that you could use any formula and you are doing very well. But in long eyes, now this is a highly myopic eye, there is a difference in the IOL power in the different readings, but these are 2 and 4. So the effect of the refractive surprise, the outcome will not be so hampered. But if you're looking at a short eye, wherein the IOL powers are 48, 52, and there is a difference in the values of two eyes, you have to become even more cautious, because a small change in your IOL power can bring a big refractive surprise. Again, in post-laser vision correction, multiple studies have told that when you do your IOL power calculations, you are better in myopic eyes, myopic LASIK eyes, less than PRK, then comes hyperopic LASIK. And in all these situations, you find if you're using your Barrett True K TK, you are actually doing good. There are certain additional measurements. All I've been talking about, 70% of the cases you are going to be doing well. In those 30% of cases when there is a challenge, when you see that your standard deviation in your readings is different, it is more than 30 micron, more than 0.2 diopters, look for dry eye. The dry eye is not there, don't give up. There's some discrepancy, rule out whether there was a refractive surgery done, is there an early KC, is there a PMD, do a tomography, use the toric IOL power calculation, do everything to get the right result. You might have done everything perfectly, but let's understand that you would have planned where the IOL sits in the bag, you would have used the best formula, but the effective lens position, that is where the lens sits in the eye, which is the distance from the back of the cornea to the implant center, that can change even in the post-operative period. It is said that the anterior chamber depth shifts from more than 1 millimeter shift can occur between 1 hour to 2 months. So then you think you have hit the nail, but then you are not there. So probably the future is wherein you would find that you have a technology which will do post-operative corrections, which would probably have something, adjustable facility which would come in. Maybe when you would say that all your patients, you planned a target emmetropia and you ended up with target emmetropia. Thank you very much.
Thank you. Next is Dr. B.P. Kashyap, who's going to be speaking to us. Any questions for Dr. Chitra? Well, Dr. Kashyap is getting ready. Dr. Kashyap, you say please.
We can take left
Dr. Love?
So I
Oh, because while Dr. Love is getting ready, would you like to comment on this total keratometry concept? I mean, what is this measurement of the posterior cornea?
see, total keratometry is a facility which is available with the IOL Master 700, wherein in n number of points on the anterior and the posterior cornea, the K value is measured. It is using a technique of swift source OCT and the B scan biometry is both combined, and it measures on the anterior cornea in different zones, 3 zones it measures. At it, because of the ability to scan the cornea, A scan, B scan, it interpolates the values of the posterior cornea, so it gives you a total corneal astigmatism. So that becomes a huge advantage if you have the K value and the posterior corneal astigmatism appropriately done. Then your toric IOL calculations, and if for that matter, all your IOL power calculations become important. But one thing you need to remember is that supposing you are measuring K value on the Barrett's and you're trying to use it in some other formulas like holiday formula or any other formula, we need to find out, because they have their own way of mathematically deriving the posterior corneal astigmatism. So if you take the total K and put it into that, then you would end up overcorrecting also. So that small issue we need to keep in mind. But having said that, you measure your total K and you can go on to place it into the Barrett formula, universal 2 or toric or TK, then you would get the best of results. I'm sure you would have a lot more to add.
Okay, thank you.
Thank you.
Over to you, Dr. Love.
Thank you, sir. And the topic on which I would be speaking is managing pre-existing PC defect. So we'll start with a pediatric eye, and what you see here is a posterior lenticonus, and which is very clear on examination, so no doubt about it. So important is don't do any hydro procedures, none of it, because we want to aspirate all the cortex without any vitreous loss. So without hydro procedures in children, it is quite easy, and always take care not to decompress the eye suddenly, because that will be a trigger for the vitreous to come in the anterior chamber. So as you see, it's gone on smoothly, and with such a large defect, the choice is ours. Either we can put a 3-piece lens in the sulcus, or in this case, I could have very well tried a single-piece lens in the bag also. So anterior vitrectomy is done as we do in all pediatric cataracts, and then the lens is pushed gently. It is a 3-piece lens which is gently dialed in the bag. So easier, since I use a lot of 3-piece lens, for me it has become a practice, but easier would be a single-piece lens in the bag. And then without just a gentle wash of the AC using cannula helps in avoiding vitreous loss. Second scenario in pediatric patients is a blunt trauma leading to a PC defect, and you can see the line of the posterior capsular defect through the total cataract. So again, avoid hydro procedures. Why I have included this video is I'll show you the error that happens when you are not careful. Cortical aspiration went off very well and without any vitreous loss, and here I come out suddenly, and what you see is vitreous popping up. And then also not realizing the mistake, the IOL is being implanted, and when you dial, it is not going. So and this all should be avoided, because this will lead to vitreous traction, and further posterior segment complications can happen. So this is the lesson learned: never decompress suddenly. And after realization, I went with the cutter, removed the vitreous from the bag, and it's a very high speed cut rate. So if you see here, you cannot see the plunger moving itself. Once it is done, then IOL will very comfortably dial and placed in sulcus. And then pilocarpine ensures that there is no vitreous, and another thing what we can use is triamcinolone. So third case will be adult case, soft nucleus. You can see the large posterior polar cataract in it, and that is when you do, in these cases, what I do only hydrodelineation, no hydrodissection. So small nucleus with hydrodelineation can be demarcated, and the nucleus comes out. Phacoemulsification done, but you are left with a large plate. So that plate, without ensuring removal of the plate without much disturbance, because we don't want any vitreous disturbance in such cases. And a funny story about posterior polar is that first 3-4 years of my career, I didn't have any PC rent. So in posterior polar cataract. Then I boasted to one of my colleagues that I have not had it ever. And after that, I had next week, and I have been having it very frequently. So while doing the cortical aspiration, till now all going fine. And we are taking care not to decompress it because of the lesson learned from the last case. But still, with all precautions, posterior polar cataract may sometimes give way, and our aim is that no vitreous loss. So here you can see a linear PC tear has occurred, and so the lens has been placed in the bag. In the sulcus with optic capture. And gently clean the visco from the anterior chamber without using irrigation, just a normal saline wash. Now coming to the last case, which is a harder grade nucleus, almost an NS3. So in this case, I took precaution that I made a slightly larger rhexis, because we want minimum manipulation of the lens. So a 4.5 millimeter rhexis may cause problems. So I went for a 5.56 millimeter rhexis. Gently with a spatula in the beneath the anterior capsule, if you sweep it, that ensures some mobility of the lens. And then slowly you start chopping it into small pieces. And goes on smoothly till now, and you can see the posterior polar intact there, and this is the stage in which we have to avoid decompression and start doing gentle cortical aspiration. And while doing the cortical aspiration, what we see that pupil is going down, pupil is becoming constricting. And with lesser visibility in such cases, better not to take chances. The iris hooks are used for expanding the pupil, and then the cortical wash restarted, and here you go, the linear PC rent identified. But again, if you are gentle and if you are careful, there will be no vitreous loss. And good red glow is very important in the microscope for these cases, to identify it at a proper time, with AC decompression avoided, lens placed in the sulcus. And gently dilated, dialed in the sulcus, no vitreous loss, and remove the hooks. Don't do a irrigation aspiration at the end, just wash the AC with a cannula. And you get a good round pupil at the end of the surgery. Thank you so much.
Thank you so much, Dr. Love. These surgeries that you have done are on high-end machines like Centurion. But what would your message be for the general ophthalmologists who do not have high-end machines?
See, if you keep the parameters bit low, less turbulence in the AC, all machines, see, once you are working with a machine, you know how to handle it, even if it is a low-end machine. So low parameters, less turbulence will lead to, you can prevent vitreous loss in such cases.
These were pre-existing PC tears which were seen once you had finished emulsifying the nucleus.
Yes, yes.
Would there be any role of OCT? And obviously we don't do a OCT for all the cases per se. We do it for macula, but not for
Anti-segment
lens.
OCT see, posterior polar cataracts in anterior segments
Correct.
OCT, if you see a posterior indentation, there are very high chances that it will give way. But again, when you are operating in a posterior polar cataract, assume that it is going to go. Then your management becomes the same in all the cases.
Thank you very much. Thank you for your nice presentation.
Regarding ASOCT, we do it in all cases. Actually, it's even been classified as three ways. One is where you see a pre-existent defect and you see some cortical matter in the anterior vitreous. Another is where the posterior capsule seems to have fibrosed down, and which is unlikely to give. Of course, as Dr. Love said, you always assume that you are going to end up with a problem, but then this helps you to pre-plan and expect an issue. And I think I like the way you maintain the anterior chamber right through the procedure while taking out your instruments and whenever the PC rent occurred. I'm making these comments because we have the time. And one good thing about these PC rents in these posterior polar cataracts is usually it's pole to pole. There's no question of extension or rounding it off and converting it to a posterior capsular rhexis, etc. And maybe the only point I would differ from is that the last case you said, in those cases you make about 5.5 to 6 millimeter. I would always err on the side of keeping it about 4.5 to 5, because most often there is always a chance you'd end up with a PCR, and in that case you want a slightly smaller rhexis to place the lens and create an optic capture. But as far as dealing with the posterior polar cataract is concerned, I think I usually call it a masala technique, in the sense, depending on the hardness of the cataract and the type of nucleus you are dealing with, you vary the way you do it, and I think you showed very good demonstrations of that.
We would now like to welcome Dr. Ramamurthy sir, who needs little introduction. He was our AIOS president also earlier, and is the chairman of Eye Foundations in Coimbatore. He will be speaking on toric IOL in difficult situations. Dr. Ramamurthy sir.
Thank you so much. I am going to be talking on optimizing toric IOL outcomes, just a few tips which are relevant. One of the basic things is do not give any weightage to the refractive astigmatism, simply because lenticular astigmatism might completely gives you a false impression about the astigmatism that you need to deal with. You don't really need an eye trace to go ahead and implant toric intraocular lenses, but just to drive home the point that I made just now, here is a case where you see that there is a significant amount. This is total corneal astigmatism. This is the internal optics, which is the lenticular astigmatism. This is from the cornea. If you see, this patient was wearing glasses, astigmatic glasses, right through his life, and almost the entire astigmatism is from the internal optics, from the lens, which is not quite rare. Once this lens comes out, obviously the cornea itself is pristine. So obviously, even though the patient was having astigmatic power in his glasses right through, he is not a candidate for a toric intraocular lens. Contrasted that with this case where the internal optics and the anterior corneal astigmatism tends to cancel out each other, so that right through the life of the patient, he or she has not been wearing an astigmatic correction in their glasses. But once the cataract comes out, this anterior corneal astigmatism is going to become manifest, and obviously this patient would qualify for a toric intraocular lens. It's extremely important that you use the right instrument and the right formula. There are several different formula that we have nowadays in our armamentarium. We usually go with the Barrett toric calculator. Actually, when we put the patient on any of our optical biometers, it is not the the go-to formula is not Barrett Universal 2 or the Barrett toric calculator. That tells us whether the patient is fit for a toric monofocal, toric multifocal, and then the entire counseling for the patient is done accordingly. This is simply because we came across several situations where the patient had been found to have minimal cylinder, talked to about multifocal intraocular lenses, but when we do the biometry, we find that the patient requires a toric intraocular lens. So we had to re-counsel the patient about the need for a toricity. So the Barrett toric calculator is our go-to formula. Based upon the outcomes of that, the entire counseling is warranted. where exactly you get this Barrett-Souter formula. There's several different biometers that is available with with these formula incorporated. But the most importantly, even if you don't have access to an optical biometer, you can go ahead into the ASCRS or the APACRS websites, and you have all these formula accessible to you. You can get your biometry done with a immersion age scan. You can do a manual keratometer, but then you can have the benefits of these modern formula to exactly calculate the IOL power that has to go in. Correct even low astigmatism with multifocals is extremely important, and as you can see over here, this was a patient who underwent a trifocal intraocular lens implant, seemed to have a less than a diopter of corneal astigmatism against the rule. We went ahead and implanted, this was about 4 years back, implanted a trifocal panoptics lens, and what the patient ended up was an excellent near visual acuity of N6, but had a significant mixed astigmatism, because of which the patient is unhappy, and you can see that he had an uncorrected visual acuity of 6/12. These situations we do laser touch-up 3 months after the primary surgery. That's what the patient was counseled for. He was an understanding patient, and he said that while waiting he'll undergo the second eye surgery. Almost a similar amount of astigmatism, but when we used a toric calculator, what we found was that the patient needed a T3 toric intraocular lens, again a T3 trifocal toric, and you see the outcome immediately. The second eye, which received a toric intraocular lens, has an excellent uncorrected visual acuity of 6/6. So after a couple of months, the patient had to undergo a cylindrical correction on the cornea. Obviously, that's the reason that even for small amounts of astigmatism, we go ahead and use the toric intraocular lenses in multifocals especially. You again have to understand that I'm often asked, what's the power beyond which you recommend toric intraocular lenses? It's not just the number alone that is important, it's also the axis that is important, because the posterior corneal astigmatism increases the amount of astigmatism that the patient has to deal with, while the anterior corneal astigmatism to some extent gets neutralized by the posterior corneal astigmatism. Look at this patient who has a 0.9, less than a 1 diopter of astigmatism, but it is against the rule astigmatism, and the calculator shows that the patient requires a T4 cylindrical correction. So obviously a candidate for a toric intraocular lens. On the other hand, a patient with the rule astigmatism almost of a similar diopter, what the formula shows is non-toric. So it's not just the number of the cylinder or the corneal astigmatism that's important. The axis is also extremely important in deciding whether you want to go for a toric or not. For us, extremely important that you understand the concept of surgically induced astigmatism. For a long time, I used to think that my temporal clear corneal incision, which is of 2.4 millimeters, creates an astigmatism of 0.44 diopters. But now we understand that the SIA just doesn't have a magnitude alone, but it has an axis also. And because of this, when you calculate the centroid value, for a sub 2.4 millimeter incision is just about 0.1 diopter. So the concept of calculating SIA has gone, especially if you have making incisions of about 2.4 millimeters. So you can either ignore it or just give a value of 0.1 diopter in these situations. And repeatable axis marking pre and intraoperative is extremely important. Depending on whatever you are familiar with, you can use any of these modalities. If you have a digital marking system, that's of great use as far as getting excellent positioning of these lenses are concerned. But if you have a good experience with any of these systems, that will also work well. I personally, I most often use a digital marking device on the operating microscope. But before that, I used to go with the slit lamp, where with the undilated pupil, we used to mark the 0-180 degrees axis, and then subsequently do a marking onto the during the surgery. An intraoperative alignment is extremely important. A very short video, and what you see over here. These are the days when I used to use a viscoelastic for introduction of the intraocular lens, and it's extremely important that these intraocular lenses are positioned rightly, and then subsequently the viscoelastic is completely removed both in front and behind the intraocular lenses. It's well shown that 87% of the rotation of the intraocular lenses occurs within the first 1 hour of the intraocular lens implantation. That's often because of the residual uh, uh, viscoelastic that's left behind, which acts as a cushion for the lens to rotate. That's the reason that you don't want to overfill these bags also, because that also creates a propensity for the lens to rotate, and that's the positioning of the lens. And nowadays what I do is this hydro implantation, where basically once the lens is the nucleus has been taken out, we just have the irrigation cannula in place. And you can see this, I specifically chose this video because you can see the lens appears to be a little uncontrolled, but even in these cases you can manage them quite well, position them accurately, and then with just the irrigation flowing you can position these lenses very well. So that does away with the variability of having to remove the viscoelastic completely. And usually what you find is the way you left the lens is the way it remains post-operatively. Residual astigmatism, if you have, we use the Barrett RX formula that tells us, for example, if you have a residual astigmatism like this, +1 with -2.5 diopters of cylinder, one thing, rotation of these lenses is going to help only if the total amount of residual astigmatism, the spherical equivalent is almost zero. That is, this and this tend to cancel out each other. In these cases you can go ahead and do a rotation of this lens. That's again a fairly simple procedure. You can also do a piggyback intraocular lens, or you can go ahead and do a laser vision correction. So the final take home tips are: multiple measurements of K reading, consider but do not be guided by the refraction cylinder, check the ocular surface even before you take the measurement. The surgically induced astigmatism is 0.1. The posterior corneal astigmatism is to be considered by the formula. You make a little longer incision, avoid overinflating. These are the surgical tips. Ensure complete visco removal. Nudge the intraocular lens onto the PC and make a slightly smaller excess, as I just emphasized, so that the lens is well encaptured in the capsular bag. Ensure that even after the speculum is off, the lens remains in position. And if there is a residual astigmatism, go ahead and rotate the nucleus, rotate the intraocular lens 2 weeks after the primary surgery. Thank you so much for your kind attention.
Thank you so much for that wonderful presentation, sir. Any special tips, sir, for pediatric cataract, cataract surgery with children who have astigmatism? You have any special tips, because all this entire presentation was for adults?
No, one very important factor is most often pediatric cataracts present with the rule astigmatism. And it is over the lifetime of the patient that the with the rule goes to against the rule at the rate of about 0.3 diopters for every 10 years of the lifetime of the patient. So even if the patient pediatric cataract had at 1.52 diopters of astigmatism, I would not go ahead and implant a toric intraocular lens, because over the lifetime of the patient this cylinder is going to change. But if it's against the rule astigmatism in a pediatric cataract, because the posterior corneal astigmatism as well as the change that is going to occur in the lifetime of the patient is going to potentiate this, it's important that you use a toric intraocular lens in these cases. So I did mention about differentiating between with the rule and against the rule. That becomes all the more important in pediatric cases. Undercorrect grossly the with the rule astigmatism, or stay away from correcting with the rule astigmatism. Against the rule astigmatism, if it's there, even for a 0.5 or 0.7 diopters, I'll go ahead and correct it.
Thank you so much, sir. Thank you for that wonderful presentation.
No. It all depends on the extent of the trauma. So obviously, if the entire capsular bag has been torn it's a very extensive. If everything is fine, it's just a perforating injury. Yeah, just a peripheral corneal scar is there. I have used in these cases, and some of those cases come to you years later when the consequences of the early trauma is not there. Then definitely toric intraocular lenses can be used. The only caveat is that you have to be conscious of the fact that the lens will remain in the place you left it during the lifetime of the patient. The bag is torn also, you can place it exactly in the bag. Exactly. I would obviously like to do only a in the bag implantation of toric intraocular lens, though occasionally we have even captured the intraocular lens in the rhexis margin and tried to stabilize the lens.
Thank you, sir. Next speaker will be Dr. Anaga Harur. She is the medical director of Anil Eye Hospital in Dombivli in outskirts of Mumbai. She is also the member of Academic and Research Committee AIOS for West Zone, and she is presently the Secretary of Maharashtra Ophthalmic Society. She will be speaking on optimizing outcomes in multifocal IUL patients. Dr. Anaga Harur, please.
Satyaji, and I would like to thank the organizers for giving me an opportunity. Wonderful conference, and it's really nice to have this midterm conference here, very well organized. So I would be speaking on optimizing outcomes in a multifocal IOL patient. So what is the main goal? Is it just 6/6 by N6 when you use a multifocal IOL patient? It's more than that. It's basically 6 by happy is what you're going to look at. So if we look at the kind of multifocal IOLs that are being used, a lot of us fear using these lenses because we fear glare and halos, because we fear that if a patient is dissatisfied, it would be as gross as we're having to do an IOL exchange. And yes, the cost is a prohibitive factor. But why do we need to know all this is, yes, with increased life expectancy, there are a lot of younger patients coming to us with surgery who are well informed, have lifestyle changes, and they need spectacle independence. And so in order to cater to all these demanding patients, we also need to be very well aware of what the options we have. Most importantly in these patients is what patient you select, what lens you select. Yes, we also need to do a good patient counseling, and precise biometry and surgery goes without saying. A suitable candidate basically would be one who is highly motivated, comes to you saying that what can you do for me, doctor, because I don't want to use glasses. It's not that you're forcing upon him that yes, we have this option, please take this option, please, that you will not need glasses. This is not the way you should, because the moment you say that, you're increasing the expectation so high that even if he has a 0.5 number and your optometrist says, हाँ आपको 0.75 है, he'll come back to you saying, I was told that I will not use glasses. So you need to have patients who are easygoing personality and have a direct connection with the patient, have a talk with him directly. What patients I personally avoid are those that are hypercritical. You keep tending to ask you 100 questions, very finicky, and if they are regularly doing night driving, long drives, I personally avoid all these patients. So what are the criteria for exclusion? Yes, you do a good preoperative workup. If there's irregular astigmatism, for example, like somebody having a corneal scar or keratoconus, macular pathologies, of course, advanced glaucoma, severe dry eye, large angle kappa, and if there has been an intraoperative event with a large nodular dialysis or a PC tear, we would refrain from using a multifocal lens. Most importantly, I would feel is we do a perfect biometry, and what is important is we also repeat these readings every time for all these premium IOL patients. Ensure that these readings are done even before they are dilated, before an applanation tonometry, because you need a very good ocular surface. That not only helps in giving an accurate biometry, but also you know what exactly the higher order aberrations are. So we also do an ocular surface assessment for all our patients, at least a T-but, look for corneal staining, and look at the OCT also to rule out, because around 10 to 15% of these patients may have a fine ERM, early lamellar macular hole, which can be missed in a dense cataract, and that is why this becomes very important. Management of astigmatism. Yes, like what sir said, what we do is we put it onto the Barrett toric calculator online and see whether the patient needs a toric or not. If it needs, then you tell him that you need a toric multifocal IOL, and also you need to discuss the options, whether the patient can afford it. And yes, laser correction as a second step procedure, but I usually prefer to do it in the first step itself. Now, how to select the lens for your patient is very, very important, because today we are spoiled for choice. There are so many lenses available that what we end up doing is basically matchmaking, which is also very important. So communicate with the patient as to what does he do in his day-to-day activities, and then select the functionally optimum lens for his visual expectations. Yes, we know that we can use both diffractive as well as EDOF lenses, trifocals, and we also need to know what are the limitations of a standard, earlier what we used to use, the bifocal IOL, which is still available now. So you have limited intermediate vision, especially for these patients, reduced contrast sensitivity, and a disabling dysphotopsia sometimes. So whenever you think of these patients, so today our indications for an extended depth of focus has increased when you know what more it can give you compared to a traditional bifocal lens. So you need to know the differences between a trifocal, for example, and an EDOF lens. And an EDOF lens will give you a better intermediate vision, less of glare and halos, better contrast sensitivity, and the kind of neural adaptation and suppression that is there in trifocals would be much lesser. There is a dip in the trifocals between the distance to intermediate, intermediate to near, which is not there in the EDOF. It's more of a continuous one, and that is why this becomes important. So the extended indications, especially in my practice, is for computer users, those who are doing night driving, post-refractive patients, or those who have mild comorbidities. You can think of doing the EDOF lenses, but yes, many of them need a reader, so you have to tell them that you might need reading glasses. So how I go ahead is, when a patient wants spectacle independence, 3 questions are asked. First is how much of night driving they do. So if they are doing a regular night driving, then either you use EDOF and you avoid using the traditional diffractive lenses. If they are doing it sometimes, then you counsel them about the glare, and if the glare or if the night driving is very, very high, then that is more important, then you avoid putting it a multifocal at all. If it's acceptable, or if they are not doing night driving, then you can go ahead and then use the second question. So the second question is how much computer work they are doing, because you need to know their intermediate vision. So if they are regularly doing that, either you use a trifocal or an EDOF with micro monovision, and if that is only sometimes, if they are affording, not affording, then depends on that. And if they are not doing any computer work, then you can use, but there are actually a lot of other things also that need intermediate vision. So given a choice, I would go in with a lens which also would cater to the intermediate vision. And also check their reading distance before you decide what is the near add that you're going to give. Because if it's a patient who is having shorter arms and doing near distance, then that would require a greater addition. So even in patients, precise surgery is also very important. So here was a policeman actually who came to us with a dense brown cataract. We did flax with a multifocal IOL. So what is important is you give a good visual outcome in all these patients. So this was patient 6, 6 and 6 the next day. Now, even though we know that we have done all that we can, if a patient is dissatisfied, then you need to know why. So these are the reasons why you would have a dissatisfied patient. So let's see just briefly. A perfect biometry is essential. So if you have a refractive surprise, first identify where you went wrong, whether you put in a wrong lens, a wrong keratometry, a wrong biometry. Second is a residual refractive error, especially in astigmatism. So whichever lens you use, especially more for a multifocal lens, if there is a residual astigmatism, the contrast sensitivity is going to reduce and the patient dissatisfaction is going to be high. So if you have a residual ametropia and you think that you have done a perfect biometry, first see how much is the residual astigmatism or the residual spherical error. So you can do probably a touch-up or you do an IOL exchange depending on at what point of time the patient has come to you. Posterior capsular opacification, these patients are very sensitive to them. Even if you have folds on the PC, that can actually reduce the contrast sensitivity. So you may need to do an early YAG and a larger YAG. 1 minute left, right? Yeah, but remember, once you do a capsulotomy, then the IOL exchange becomes even more risky. CME is something which you need to detect early because a lot of these patients may have a subclinical one, so doing an OCT would help. Remember to check for the ocular surface and dry eye. If there's a decentered lens, if you remember that if there could be a lens that is not perfectly centered, that itself can induce astigmatism and higher order aberrations. We know that diffractive lenses can cause unavoidable scatter, and that increases the chances of glare and halos. Do not ask leading questions, and if the patient still comes to you with that, reassure that the lens is working and wait, because neuroadaptation will help to reduce their problems. So these patients may take many weeks to many months also, and those patients who are younger, more easygoing and motivated will have faster adaptation. Ensure that the lens is centered well. Angle alpha is important, and you can do this pre-operatively even with the IOL master or with the eye trace. Large angle kappa can cause edge glare effects, And if there are patients with previous refractive surgery, hitting emmetropia may be difficult, and because of raised higher order aberrations, that can cause more night vision issues. So basically counseling is very important. Give them realistic expectations. Do not give them 100% guarantee that they will not need to use glasses at all. So undersell and over deliver. Special consent we usually take for all these patients. More chair time pre-op is always better. Thank you so much for your kind attention. Thank you.
Thank you so much, Dr. Anaga. Wonderful presentation, very nice. I just wanted to know the incidence of, in your practice, you took care of everything and still you had to do an IOL exchange because the patient was very unhappy.
So it no, I have not had a
You
case
have not
like
had
that.
that.
No, we have had a patient where there was a refractive surprise with a toric multifocal IOL, but it was the wrong IOL power from the manufacturer's side.
And what are your views on EDOF IOLs in pediatric cataracts?
See, in pediatric cataracts, it's a growing eye, depends on what age you want to do the surgery. But if it's, say, a 10, 12-year-old and you have a good, well-centered lens, and if there's no other problem like any subluxation or anything, you can still go ahead and use, but depends on other comorbidities also. If it's a traumatic cataract, if it's just a plain pediatric cataract, a good posterior capsule, then I think you can
So
go
what are
ahead
your
and
views
use.
on EDOF lenses for pediatric cataracts?
We have used EDOF, even trifocals in pediatric cataract. With pediatric, if you're talking about less than 6 years, no. But beyond 6 years, when most of the maturation of the apparatus and the growth of the eye has happened, we've used it trifocal lenses also. And there have been instances, and even the earlier array lenses, a few of them we have used. And when the patients cross the age of 18, we have done a laser touch-up for these cases. The not needing a reading glasses definitely helps. I do agree, know that not all pediatric ophthalmologists agree with this concept, but then in our hands it has worked. Less than 6 years we don't use it, but beyond 6 years we don't mind using these, especially the current crop of good trifocal lenses as well as EDOF lenses.
Sir, have you given?
Only thing, sir, when refraction changes, like in children, if you are using multifocal, the refraction will change. But even with spectacles, dependence on progressive will not be.
That's exactly what I'm saying. You know, they end up needing a -2, -3, -2 with some cylinder, but they are not wearing progressive. And since we have been around for quite some time, there are instances when the patient has reached the age of 20 or so, when you've done a further laser vision correction to get rid of that power also.
Any instruction? Any instruction do you give to your optometrist while doing a primary assessment for the glasses when they check for the refraction?
I tell them, you know, very often the patient comes in very happy and comes out of the optometry lane feeling very unhappy. So I tell them the patient is happy, don't go around looking for that 0.25, 0.5 diopters of refractive error. So if the patient is comfortable reading even 6/9 in one eye and 6 in the other eye, bilaterally implanted, they are quite all right, then just leave them fine. And another important thing is don't over minus these patients. You know,
So in my experience, you know, what I've seen that the patient comes in, the patient is taken for the auto-ref, and they do the refraction, and even if the multifocal is there, they put the addition of 2.5 and say, yeah, you need glasses, you are doing fine. They are to be instructed that, you know, you have to see what lenses that they are given and then do the refraction. Point number 1. Point number 2, the auto-ref gives a fantastic results for the aphakia and monofocal IOLs, but it's gives you absolutely absurd reading for the toric IOL. It gives you a lot of astigmatism, and which is not there. The patient is reading 6/6 and the reading gives you, you know, some is spherical and high -2.5 cylinder and some axis. So the auto-ref gives you absolutely absurd finding in case of toric IOL.
Thank you very much, Dr. Anaga. Thank you for that wonderful presentation. Our next speaker will be Dr. BP Kashyap, who is the chairman of Kashyap Memorial Eye Hospital from Ranchi. And he'll be speaking on capsular axis in intumescent white cataract, different ways, choose your own way. Dr. BP Kashyap, please.
Hi, good morning everybody. The most dreaded complication of the intumescent white cataract is the Argentinian flag sign. A lot of people have said a lot of ways. I also started a lot of ways. We started with the spiral axis, and then putting this 26 gauge needle and sucking out, milking out the capsular matter and the cortical matters. And there was recently Dr. Arvind Maurya has come out with the sieving needle method. He give the punch and then he starts doing the rexis. But what I feel is the so popularized by Dr. Mohan Rajan, the Panchorexis, which I started in 2014, was a Ashoka Chakra sign to replace Argentinian flax. And just want to give you the glimpse of that. So when I started, I also did a spiral capsulorexis using high viscous fluid, debulking it in between. This is an old video. We started with a small rexis, then extending it to the bigger one, to the desired one. This is the second one. This is not a white intermittent cataract. It is just for the demonstration that you start with a very small rexis, very small, and then extend it to the desired size of rexis. But this nanophaco for Ashoka Chakra, like Panchorexis, it works fantastic. You punch, stay there for some time, remove it after putting the viscoelastic, and continue with the rexis. You have to have the trypan blue. Another case, give a punch. You don't have to come out immediately. In the last two clippings, I'll be sharing you more details. So this is the rule rather than exception. It's not a fluke. It goes on very well. It has the learning curve, of course, but certain tips I'll give you. So for doing this, you have to make a very small side port, so that you could the since hook can enter. It doesn't leak fluids from there. Another case. Good Ashoka Chakra sign, and then go ahead with the rexis, very controlled one. All you have to see that sometimes the zonules are weak, so you have to be very, very careful. Sometimes the capsules are thick, you have to be very, very careful. Another case. Now, if you do not do it properly, then Argentine flax sign will happen. See, I am in quite periphery, and then this happens. So if you're trying all these things, you have to be, expert in converting all kinds of rexis into a proper rexis, and which is not tough. I always remove my speculum and see the condition of the anterior chamber. Another case, when the Argentinian flax sign happened, again look at, I'm in quite in periphery. If you start here, it will happen. Now, please look at these, the newer ones. I go in the center, look at the parameters. I foot pedal 1, 2, 1, 2, and then give a punch at the punch, hold it there, keep on sucking the fluid, keep on sucking the fluid, absolutely no problem. And then remove it, put the viscoelastic and then complete it. Next case, go inside, irrigation on, off, and then quad mode, give a punch, hold on, keep on sucking the fluid, keep on sucking the fluid, keep on sucking the fluid, inject the viscoelastic, and then complete your axis. So this makes your life very, very easy. That's all I had to say. Thank you.
Nice presentation, Dr. Kashyap. Well, last speaker, Dr. Ankit is getting ready. There are instances when you have to evacuate the cortical matter a number of times. Here you are doing it only once in the initial, then subsequently also while you are completing the rexes, do you sometimes have to go ahead and evacuate the cortex because you run into bumps?
No, sometimes if you do the first go, you are sucking quite a lot of them. You press it, suck it, so quite a bit of cortical matter comes out. And then when you inject the viscoelastic and start doing the rexes, proper rexes by the rexes forceps, so sometimes you have to suck a little bit more, inject more fluid, more viscoelastic. So it is very, very controlled. It is very, very controlled. What I want to emphasize is you don't give a punch and come out. You are doing more harm than the good. That you have to take care.
Thank you.
Thank you.
Over to you, Dr. Ankit.
Thank you, sir. So, first of all, I would like to thank AIOS Scientific Committee for giving me this wonderful opportunity. Now, this talk was supposed to be at the beginning because it's just choosing the phaco machines for the beginners, but due to some technical error, I was not able to. Now, I have no financial interest in the products or the machines which I have depicted in this presentation, and there's a disclaimer that the settings and machine parameters which I will show here and describe here are my own personal settings, and these are highly individualized. Each person has their own style of working, their own skill set, and the settings may change as per the skills. Now first I will start about showing the settings in the how they look on a phaco machine. So first is the IOP. IOP or bottle height are the same thing. IOP is shown by Alcon people and the bottle height in the other machines. So, and the other setting is the vacuum, and third is the aspiration flow rate. And the last setting is the phaco power, which is determining the hardness of cataract. This is how it is shown in an AMO or J&J machine. That is, the bottle height is there on top here. The phaco power is here, the vacuum is here, and aspiration flow rate is here. Coming to some basics, the bottle height, because it's water, so it's approximately 0.73 into the bottle height in centimeter is the IOP in millimeter of mercury. Higher IOP results in deeper chamber and lesser surge, and this is especially important for beginner surgeons and in those who are operating on low-end machines. A lower IOP has shown to be less traumatic to endothelium. Also, the patient does not feel much pain during topical phacoemulsification when a lower IOP settings are used. Lower IOP settings are important in IFIS, where if the intraocular pressure has increased, the more iris floppiness occurs. In high myopia, the rooms are already weak, and if IOP is increased, the chamber becomes uncomfortably deep for doing a good phacosurgery. And in cases of PCR, we have to do the phacoemulsification at very low parameters by bringing the nucleus in the AC and keeping the IOP very low. In general, for high vacuum procedures like CHOP, quadrant removal and viscoelastic removal, a higher bottle height is desired. The standard bottle height which is used by most phacosurgeons is 90 to 110 centimeters and giving an IOP of 60 to 70 millimeters of mercury. Now what is AFR? It is the speed of fluid being aspirated by the phaco handpiece, and AFR is as a rule of thumb, what I keep is AFR, that is bottle of height in centimeters divided by 3. which gives a very optimal control in the chamber. In a peristaltic machine, vacuum is engaged once occlusion occurs, while in a venturi machine, the AFR is basically caused by the vacuum. The hold of the occluded piece depends on the vacuum, thus a good hold is required for chopping and also emulsification. When occlusion breaks, there is a sudden gush of fluid into the phaco probe, causing sudden lowering of the IOP, which is basically called surge. And to lessen the chances of surge, vacuum should not be set more than 10 times of the AFR, that is on a low end machine and for beginners. And lastly, the power. It is the amount of energy with which the phaco handpiece emulsifies the nucleus, and the higher power required for denser nucleus, lower power required for softer nucleus. Power is controlled by foot position 3. Now coming to some machine setting which I use. First, the pre-phaco, that is basically clearing the cortex before starting the main phaco emulsification. Here, the bottle height I keep is normal, 90 to 100 centimeters. The vacuum is medium-low, that is 150 to 200. Power, not much power is required because this is already emulsified piece. This is just cortex. So 10 to 20 power is more than sufficient. And also a medium-low aspiration of 25 to 30 is more than sufficient for this purpose. Coming to next, sculpt. These settings for vacuum and aspiration are generally kept same for all the grades of cataract and sculpt mode. Vacuum is 150, 200 or even lesser. Sometimes up to 100 is sufficient. The aspiration of 25 is sufficient, while the power changes as per the mode of grade of cataracts. In NS2 cataract, a power of 30 to 40 is more than sufficient. In NS3 to 4 cataract, a power of 50, 60 or sometimes 70 may be required depending on the grade of cataract hardness. And in a NS5 cataract, a power of up to 100 may be required. What is most important is that one should one can make multiple passes to keep a deep enough trench, which is important because a trench depth of up to 70 to 80% minimum is required for a good breaking of the nucleus. Also, the trench should be boat shaped, that is in the center it should be deeper, in the periphery it should be shallower, because the nucleus is thicker in the center and shallower in the periphery. Coming to chop and quadrant removal, in this mode the nuclear pieces are divided and aspirated by the phaco handpiece. Here the settings which I keep are aspiration of 30 to 38 and a vacuum of 25 to 300 and a power of 30 to 40. The bottle height is same, that is 90 to 110 centimeters. In NS2 cataracts, power 30 to 40 is more than sufficient. In NS3 to 4 cataracts, a vacuum of 300 to 350, a power of 40 to 50 is sufficient. Because in this mode, too much power we should not use because we are doing little bit above the at the pupillary margin. Too much CDE may damage the endothelium, and because the second instrument is there, we can do some bit of chopping using that. While in a NS4 to 5 cataracts, a power 60 to 80 may be required. A vacuum of 350 to 450 is used in this because a very good hold is required to do efficient chopping. Here you can see there are a few bubbles above the phaco handpiece which depict, and they are not getting disturbed much, which depicts that the nuclear pieces are not coming in contact with the cornea. Hence, in the post-operative period, corneal edema will not occur. Now, last is epinucleus removal. In this, high vacuum, low power and low aspiration settings are used because the epinucleus and the posterior capsule are very thin and a sudden surge may cause PCR. Here, a low aspiration of 26 to 28, a vacuum of 350, while a power of 220 is more than sufficient. In cortex removal, aspiration of 30, a vacuum of 350 to 400 is required. Bottle height remaining same because cortical pieces, once they are occluded by the aspiration, have to be sucked in. So a good vacuum is required. An important tip for beginners is that if using bimanual, the irrigation we can use is 20 or 21 gauge and the aspiration should be thinner, that is 23 gauge. This helps in keeping the AC more stable, as aspiration is more limited as compared to the irrigation. Catheter polishing, low aspiration, low vacuum settings, aspiration of 10 to 15 and vacuum of 80 to 100 is more than sufficient. Here I am using a sandblasted cannula for catheter polishing, which really helps in removing all those sticky fibers. In viscoelastic removal, high aspiration, high vacuum. Here I don't have any fear of getting the posterior capsule getting caught in the probe because the nucleus, because the PCI is acting as a scaffold here. An aspiration of 34 to 40 and a vacuum of 350 to 400 can be used. Lastly, no machine settings are ideal. It depends on the surgical style, the phaco machine and the surgeon's skill set. Thank you.
Thank you. I think you emphasized several very important points. Any questions for Dr. Ankit? Just one question. Do you use longitudinal and torsional phaco or ellipsoid phaco? What's your choice? Do you always use one type of?
Right now I'm using Signature Pro machine, so ellipse I use for all the cases.
Thank you. I think that brings us to the end of this session. Thank you all so much for joining us. Thank you.